currently we have two first-generation EGFR TKIs, erlotinib and gefitinib. We have one second-generation agent, afatinib, and one third-generation agent, osimertinib. These are all EGFR TKIs. The difference is that the first-generation agents are reversible inhibitors, and they do inhibit wild-type EGFR. The second-generation agents are irreversible inhibitors, and the third-generation agents are active against the native mutations or the common mutations, and also active against T790M. T790M is the major acquired resistance mechanism from first and second generation agents. So until recently, we would typically use a first or second generation agent. The average patient would have control of the disease for about a year, and then they would progress. We would rebiopsy them or plasma test them to try to find T790M. You found T790M in about 60% of patients, and you used a third generation drug, osimertinib. We recently had data from the FLORA trial in which osimertinib, the third generation agent, was compared in a phase 3 trial against the two first generation drugs, gefitinib and erlotinib. And it was a positive trial in favor of osimertinib. The progression-free survival hazard ratio was in the range of 0.47 or 0.46, so slightly more than a 50% risk reduction in progression of disease. The response rates were about the same. They were at 76-80%, but the duration of response with osimertinib was significantly better than it was with the first generation drugs. And an initial early look at survival, although it wasn't statistically significant, it was, in my opinion, clinically significant in favor of osimertinib. So you have response durability, progression-free survival benefit. I think was a clinically important survival benefit, although not statistically significant. And it was less toxic, less rash, less liver function abnormalities. So it's kind of like tastes great, less filling. It's a better drug. It's changed my practice. Where formerly I would use their first or second generation drug. I think the FLORA data is compelling that I have switched my first line treatment to osimertinib in patients with either exon 19 or exon 21 EGFR mutations. The optimal management of brain metastases in patients with lung cancer, particularly with an oncogenic driver, should be in the context of a multidisciplinary team. We rely heavily on our neurosurgeons, on our radiation oncologists. There's an expanding role for stereotactic radiotherapy or gamma knife therapies. There also continues to be a role for whole brain radiotherapy, although we certainly do that as a last-ditch effort in patients like this. We also know that this is a population that can respond to oral therapy. A drug like osimertinib very effectively gets into the brain, and the brain can respond just as well as the rest of the body. So I think the teaching point for the kind of the multidisciplinary radiation oncology neurosurgical team is it shouldn't be a knee-jerk reflex to do radiation. I would give this patient, if her symptoms got better on dexamethasone, then I would give this patient osimertinib and follow the brain and try to save radiotherapy as the next option for the brain when these TKIs fail.